Welcome to The Critical Edge, the no-nonsense podcast breaking down the latest game-changing evidence in trauma and surgical critical care to give you the edge when things get critical.
Right on.
So imagine pushing a standard dose of propofol to secure an airway on a, combative bleeding trauma patient.
Right, a routine muscle memory move you've executed, 100 times in your career?
Exactly. But now imagine that routine move instantly and irreversibly stopping their heart.
Oof, yeah, it's a terrifying scenario.
It really is. So today we are launching into a deep dive that takes us out of those pristine, temperature-controlled, fully staffed operating rooms we're used to in the civilian world.
Yeah, we're dropping directly into the austere, high-stakes, severely resource-depleted environment of the forward surgical tent.
Exactly. Our mission today is highly specific. We are dissecting the seminal book chapter, Torso Trauma on the Modern Battlefield, by Matthew J. Martin, Brian Eastridge, and Matthew D. Tadlock.
Heavy hitters in the field.
Oh, absolutely. And our objective here is to extract these hard-won battlefield data points, the operative paradigms, and the resuscitative pearls that these military surgeons have basically forged under literal and metaphorical fire.
And translate them directly into actionable intelligence for your clinical practice.
Yes. And to be unequivocally clear right from the jump, we are speaking directly to you, the U.S. trained trauma and surgical critical care surgeon.
Right, because we know you might not be operating in a Candace 10 ticket.
Yeah, you probably aren't dealing with the immediate dusty aftermath of a mortar strike every day.
But the physiologic extremes, the profound tissue destruction, and these unforgiving lessons on non-compressible hemorrhage that are detailed in these sources, they are directly, urgently applicable to your next level 1 mass casualty event.
Or your next multi-vehicle high-speed pileup.
Exactly. Or that devastating industrial crush injury that rolls into your trauma bay at 2:02 a.m. on a Tuesday.
Because the physics of the trauma might have different origins, but the human physiologic collapse?
The lethal triad.
Right. That spiraling lethal triad of hypothermia, acidosis, and coagulopathy. That is universal.
It's a massive landscape to cover.
It is. So, just a quick roadmap. We're going to dig into the epidemiology of modern combat wounds to understand exactly what we are fighting.
And here modern body armor has completely shifted the injury patterns you actually see.
Right. Then we'll evaluate the critical, non-negotiable do's and don'ts of initial evaluation, which includes that major practice-altering warning about the dangers of early intubation that I just hinted at.
That part is huge. Then we'll break down the advanced resuscitative care protocols.
Looking at the biochemistry of whole blood versus component therapy and the deployment of austere REBOA.
And finally, we'll get deep into the surgical weeds. Specific damage control operative techniques for the chest, the abdomen, and the absolute nightmare scenario of the massive pelvic blast wound.
These are the clinical paradigms that basically separate acceptable outcomes from exceptional salvage.
So let's establish the baseline of what we are actually fighting here.
Right, the data.
Yeah. When we analyze the data from the Joint Theater Trauma Registry, the JTTR, spanning from 2001 to 2009, we see a fascinating and honestly somewhat counterintuitive shift in the epidemiology of survival.
How so?
Well, truncal wounds represent a 15% overall incidence in combat casualties. Breaking that down anatomically, with about 6% thoracic and 11% abdominal.
Okay, pretty standard.
But the standout statistic here, the one that really makes you pause, is the thoracic data. We are seeing a 50% reduction in major thoracic wounds compared to previous major conflicts.
Wait, like compared to Vietnam or World War II?
Exactly. A 50% drop.
Right, and that drop is almost entirely attributed to the widespread deployment of modern personal protective equipment, right? Like the rigid ceramic body armor plates.
Yeah, the plates are doing their job.
But, I have to push back on this, or at least look at it from the perspective of a civilian trauma surgeon looking at overall mortality. If body armor is so incredibly effective that it reduces penetrating thoracic injury by half, why is torso trauma still such a massive, lethal problem for the combat surgeon?
It's a great question.
Shouldn't the torso essentially be a solved anatomical region by now?
You'd think so, but it speaks to a fundamental misunderstanding of kinetic energy transfer.
Okay, walk me through the physics.
What's fascinating here is the concept of survivorship bias, combined with the mechanical conversion of injury patterns.
Right.
The ceramic armor plate doesn't make the massive kinetic energy of a high-velocity 7.62 rifle round or a rocket-propelled grenade just simply vanish.
The energy has to go somewhere.
Exactly. It arrests the penetration and disperses the energy. So the armor frequently converts what would have been an instantly fatal penetrating wound in the field.
Like around directly through the ascending aorta.
Right, or the right ventricle. It converts that into a highly severe but initially survivable blunt trauma.
Oh, you're talking about the back face deformation of the armor plate physically punching the chest wall?
Precisely. We are talking about massive chest wall contusions, severe multi-level rib fractures, flail segments.
And underlying profound pulmonary contusions from the spall and the blunt force.
Exactly. Because the armor prevented immediate exsanguinating death from great vessel penetration, a much higher volume of critically injured, physiologically brittle patients are actually surviving the initial point of injury.
So they live long enough to reach the forward medical facility.
Yeah. They arrive alive, but, they are hanging by a physiological thread.
Okay, I follow the physics. They survive the initial kinetic impact, they make it to the surgeon's table, but they are still dying at high rates once they get there.
Unfortunately, yes.
So what is the actual mechanism of death in these survivable wounds?
It's noncompressible torso hemorrhage, NCTH.
The beast itself.
The JTTR data explicitly shows that approximately 50% of all potentially preventable deaths among patients with survivable wounds are still due to NCTH.
50%. Wow.
Yeah. You have a patient who absorbed a massive blast wave, survives the primary fragmentation thanks to their armor, but the extreme blunt force or the transitional shock waves cause profound internal shearing.
Right, of solid organs and axial vessels.
Exactly. And this unique, devastating combination of severity prompted the military to realize that standard civilian scoring systems were basically failing them.
They needed a new metric.
They had to develop the military ISS or MISS.
No, I really want to dig into that because in civilian practice, the injury severity score, the ISS, is our absolute bread and butter.
Oh, 100%.
We use it every day for trauma research and quality improvement. But the source points out that the MISS boasts superior sensitivity and predictive ability over the civilian ISS for these specific blast and fragment profiles.
It does.
Why? Why does our civilian ISS fail when the physics shift to explosions?
Think about how the standard ISS is actually calculated. It takes the abbreviated injury scale, the AIS, and it squares the top scores of the 3 most severely injured body regions.
Right, some of the squares.
But the fatal flaw in the civilian ISS is that it only allows you to count 1 injury per body region.
Wait, really? So if a patient is in a high-speed MVC
and has a ruptured spleen and a shattered liver?
The ISS only scores the single worst abdominal injury.
Exactly. It completely ignores the cumulative physiological burden of having multiple catastrophic injuries in the exact same anatomical cavity.
Which makes sense for a steering wheel impact, perhaps, where it's a localized point of pressure, but that completely falls apart with a blast wave.
Exactly. An improvised explosive device, an IED, doesn't respect anatomical boundaries.
It's indiscriminate.
Right. A blast wave will simultaneously shred the liver, rupture the spleen, avulse the mesentery, and contuse the bowel.
So the civilian ISS drastically underscores that patient.
It makes them look statistically much more likely to survive than they actually are. The MILIS mathematically corrects for this, accounting for multiple severe injuries within the same body region.
Giving a much more accurate prediction of mortality and resource utilization for blast mechanics. It's a brilliant mathematical adaptation to a pretty grim reality.
Yeah, it is.
And speaking of grim realities, if we connect this to the bigger picture of non-compressible torso hemorrhage, we have to look at how the military rigorously defined the problem.
Because for a long time in the trauma literature, non-compressible hemorrhage was a pretty nebulous, poorly defined term.
What does it actually mean?
But Martin and his co-authors provide strict, dual criteria, anatomic and physiologic.
Yes, and that duality is what makes it clinically relevant.
Okay, break it down.
Physiologically, NCTH is defined as a state of profound shock. Specifically, a systolic blood pressure less than 90 millimeters of mercury, or the absolute need for emergent life-saving surgery to control bleeding.
Okay, so they are crashing.
Right. And anatomically, it requires specific injury patterns, a named axial vessel injury, a solid organ injury of grade 4 or higher, or a major pelvic disruption.
So you need both.
Right. When they applied these strict combined definitions to the JTTR, they found that about 13% of battlefield casualties met the anatomic criteria alone.
But only 2% actually met the full NCTH criteria, meaning the severe anatomy combined with the profound physiologic decompensation.
And the statistical breakdown of mortality within that 2% is where the reality just hits you in the face as a surgeon.
Yes, staggering.
They calculated the odds ratios for mortality based on the specific anatomical source of the bleeding. So injury to a named axial torso vessel carries an odds ratio for death of 3.4.
Wow.
The thoracic cavity in general is 1.9. Solid organ injury greater than grade 3 is 1.0, and a pelvic ring disruption is 0.8.
So an OR of 3.4 for a named torso vessel.
That means if you take two casualties with identical MINS ISS scores, the one with an injury to the aorta, vena cava, or iliac vessels has odds of dying that are almost 3.5 times higher.
The margin of error is virtually zero.
It really is, and we must translate this directly to your civilian practice.
Absolutely, because you might be listening to this thinking, well, I operate in Chicago or Los Angeles. I don't see IEDs on a daily basis.
Right.
But civilian trauma registries, looking at major level 1 centers, show a remarkably similar incidence of NCTH, right around that same 2% of the overall trauma population.
Wait, really? 2% in the civilian centers, too?
Yeah. The difference is just the mechanism. In the civilian world, the predominant mechanism driving NCTH is severe blunt trauma.
Like high-speed motor vehicle collisions.
Auto-pedestrian impacts, industrial crush injuries.
Right.
Yet just like in combat, NCTH accounts for a massive 45% to 85% of potentially preventable bleeding deaths in civilian centers.
So the mechanism of energy transfer differs, but the lethal pathophysiology,
the rapid exsanguination into a cavity you cannot simply hold pressure on,
is identical.
Oh, go.
Which brings us perfectly to the mechanism of injury itself. How the physical mechanism dictates our very first critical moves the second that patient rolls through the doors of the trauma bay.
Right.
We've transitioned from the wars of the 20th century, which were predominantly gunshot wounds, point A to point B kinetics,
Right.
to the defining weapon of the modern battlefield,
Yeah.
the IED.
The IED fundamentally rewrote the rules of trauma surgery and resuscitation.
I was actually trying to come up with an analogy for the civilian surgeon to visualize the IED wound profile, because it's not just a bomb, it's a multimodal assault on human physiology.
It's everything all at once.
Right. It is as if you took a horrific multi-car highway pileup, combined it with a severe flash burn, and simultaneously hit the patient with a close-range shotgun blast.
That is an incredibly accurate, albeit terrifying, clinical picture.
You have the primary blast wave causing extreme barotrauma to hollow organs and pulmonary alveoli.
Yeah.
The secondary blast throwing penetrating dirt, metal, and fragments at hypervelocity. The tertiary blunt trauma from the patient being thrown against a wall or their armored vehicle rolling over.
And finally, the quaternary thermal injury from the explosion's fireball itself.
Yep, exactly. And because you, as the receiving surgeon, are facing that simultaneous forefront physiological assault, the golden rules of your initial evaluation have to be ruthlessly disciplined.
Oh, absolutely. When that patient rolls into the bay, it is incredibly easy to be visually distracted.
The shiny objects, so to speak.
Exactly. The source text is absolutely adamant on this point. You must initially ignore drastic appearing extremity wounds as long as they are hemostatic.
Right. A mangled, traumatic amputation of the lower leg looks terrible.
It draws the eye of every nurse and resident in the room.
But if the pre-hospital tourniquet is properly applied and holding, that leg is not what will kill the patient in the next 3 minutes.
Right. You have to maintain severe tunnel vision on the torso. You must assume a tension pneumothorax, and you must assume non-compressible torso hemorrhage until definitively, objectively proven otherwise.
That means immediate use of the FAST exam, the extended thoracic ultrasound to look for lung sliding, or a diagnostic peritoneal aspirate, the DPA.
Yes.
I want to highlight the DPA specifically because we often rely so heavily on the FAST exam now.
We do.
The text notes that if you get gross blood erysipelas on a DPA, and there's no obvious massive ultrasound source, that mandates an immediate exploratory laparotomy.
No waiting for a CT scan.
No, let's trend their lactates. You go to the OR.
Exactly. The reliance on advanced cross-sectional imaging, the multi-slice CT scanner, is a luxury of a hemodynamically stable patient.
Which these patients are not.
Right. In this environment, time is blood. You cannot transport a patient with an SBP of 70 to the scanner.
It's a death sentence.
It is. But this brings us to one of the most vital clinical pearls in the entire chapter, and it directly challenges a deeply ingrained, almost reflexive action in civilian emergency medicine and trauma surgery.
Okay, here is where it gets absolutely fascinating. The source issues a massive bolded warning against early intubation in the emergency department prior to adequate volume resuscitation.
Yes. Sure.
As trauma surgeons, our ABCs are hammered into us from the first day of medical school. Airway, airway, airway.
Always secure the airway.
Right. A patient comes in chaotic, combative, hypotensive, pulling at their lines, and the immediate overwhelming instinct of the trauma team is, we need to secure the airway. We need to paralyze and intubate to control this chaos.
It's a natural instinct.
But the military data is screaming at us that doing this can be a fatal iatrogenic trap.
It is the trap of post-intubation cardiovascular collapse. We really need to break down the physiological why here, because it is literally the difference between life and death.
Break it down.
You have a patient with noncompressible torso hemorrhage. They have lost half their circulating blood volume.
Right.
They are in profound hypovolemic shock. At this exact moment, the only thing keeping their systolic blood pressure even marginally compatible with cerebral and coronary perfusion is a massive endogenous catecholamine surge.
Their sympathetic nervous system is screaming.
Exactly. They are clamped down, their systemic vascular resistance is sky high, and their venous capacitance vessels are squeezed tight to maintain whatever meager preload is left.
Let me use a fluid dynamics analogy here. Think about trying to draw water through a flimsy paper straw.
Okay.
If you suck too hard, the negative pressure collapses the straw. The endogenous catecholamines, the epi and norepi their body is dumping, are the only thing keeping that vascular straw rigid.
That is exactly right. And then we decide to push standard induction agents to secure the airway.
Right. If you push propofol, or even a combination of fentanyl and midazolam, you cause a profound, immediate sympatholysis.
You chemically obliterate their compensatory mechanism.
You melt the straw.
Yes. Suddenly, that sky-high systemic vascular resistance drops to zero. The clamped-down venous capacitance vessels instantly dilate, pooling whatever blood they have left in their periphery.
And it gets worse.
Oh, much worse. You combine that chemical sympatholysis with the mechanical insult of positive pressure ventilation.
Oh, right. Because when a patient is breathing spontaneously, even if they're struggling, they are creating negative intrathoracic pressure.
Exactly. That negative pressure acts like a vacuum, helping to pull venous blood from the inferior vena cava up into the right atrium.
The moment you slide that endotracheal tube in and squeeze the bag or hook them to a ventilator, you transition them to positive intrathoracic pressure.
You are essentially blowing air back down the line.
In a patient whose tank is already empty.
Right. This combination of chemical sympatholysis and mechanically decreased preload leads to rapid, irreversible cardiovascular collapse. They code.
This is the classic post-intubation traumatic arrest.
It happens so fast.
So think about your own bay. For you, the trauma surgeon listening right now, when that crush injury rolls in tonight, your instinct is going to be to push the drugs and pass the tube.
You have to fight it.
What does this data mean for you? It means you have to actively resist the urge to neurologically control the bleeding patient with an endotracheal tube unless there is profound objective hypoxia or an absolute physical mechanical airway obstruction.
Like massive maxillofacial trauma.
Right. The guidelines now strongly favor the liberal use of ketamine.
Because ketamine is pharmacologically unique. It preserves and can actually enhance sympathetic drive by inhibiting catecholamine reuptake.
Exactly. You temporize with dissociative doses of ketamine. Yeah. You maintain their spontaneous respiratory drive. You use a bag valve mask to assist ventilation if needed, but you delay the definitive intubation until that patient is physically on the operating room table.
Fully prepped with betadine from chin to knees, draped, and the surgeon literally has a scalpel in hand.
And this raises a critical logistical point about team dynamics. By delaying intubation to the OR, you are acknowledging that the cardiovascular collapse upon induction might still happen.
Right, it's still a risk.
But you are ensuring that the moment it does happen, the surgeon is standing there ready to instantly perform a resuscitative thoracotomy or a massive midline laparotomy for cross-clamping, hemorrhage control, and massive volume replacement.
You simply cannot afford that circulatory collapse to happen in the ED while you're waiting for an elevator or a transport monitor.
It's a profound paradigm shift. We are prioritizing the C circulation and resuscitation over the A airway in the specific context of exsanguinating NCTH.
It's hard to unlearn, but it's essential.
So you've temporized the hemodynamics, you've held off on the tube, the clock on ischemic time is now ticking loudly. That brings us to Advanced resuscitative care.
ARC.
What exactly are we filling the tank with before we cut?
The Committee on Tactical Combat Casualty Care, the COTCCC, has completely shifted the paradigm here, moving away from civilian standards. Their guidelines now strongly favor FDA-compliant, cold-stored, low-titer type O whole blood, LTOWB.
Now, I have to play devil's advocate here because for years in the civilian sector, we've relied on component therapy.
The 1.1.1 massive transfusion protocol.
Right. Packed red blood cells, fresh frozen plasma, and platelets. We were taught that we were essentially reconstructing whole blood on the fly. But the military source explicitly states that whole blood is vastly superior. Why is our 1.1.1 protocol failing these patients?
Because reconstructing blood from cold-stored components is a biochemical illusion.
An illusion.
Yeah. Let's look at the actual pharmacology and fluid dynamics of 1.1.1. When you hang a bag of packed red cells, a bag of FFP, and a bag of platelets, you are not delivering the physiological equivalent of what the patient bled out.
Okay.
You are delivering a product that is highly dilute. The final hematocrit of 1.1.1 is usually around 29%.
Compared to the 38 to 45% of whole blood.
Exactly. Furthermore, to keep those separate components viable in the blood bank, each bag is loaded with massive amounts of citrate anticoagulants and storage solutions.
And citrate binds calcium, which is absolutely required for the coagulation cascade.
Exactly. You are inducing hypocalcemia and a profound dilutional coagulopathy, while simultaneously exacerbating the metabolic acidosis of trauma because of the acidic storage solutions.
So we're making them colder, more acidotic, and less able to clot.
It feeds the lethal triad. Whole blood, on the other hand, provides a higher hematocrit, significantly higher and more concentrated physiological coagulation factors, and crucially, fully functional platelets, all in a single bag with a fraction of the anticoagulant load.
And when cold-stored LTOWB isn't available, the military relies heavily on the walking blood bank, right?
Oh yeah, drawing fresh whole blood from pre-screened soldiers and transfusing it warm, straight into the casualty.
Think about the biology there. The hemostatic power of warm, fresh, whole blood with perfectly active, unstunned platelets and fully functional clotting factors is unmatched.
It rescues patients from the coagulopathy of trauma far better than our cold components ever could.
I know the logistical overhead of maintaining LTOWB in a civilian center is massive.
Yeah, worrying about anti-A and anti-B titers causing hemolysis.
Exactly, but the military data suggests the survival benefit far outweighs the logistical headaches.
It does, and this pairs directly with the second pillar of advanced resuscitative care, the austere use of REBOA, resuscitative endovascular balloon occlusion of the aorta.
Yes.
The authors provide a highly illuminating retrospective look at a 6-person austere surgical team operating over an 18-month period. They placed REBOAs in 20 patients. Out of those 20, they only had one procedural failure, which was a balloon rupture placed in zone 3.
I really want to emphasize the severity of the patients in this cohort. In this 20-patient review, the initial mean heart rate was 129, and the initial mean systolic blood pressure was 71.
They were practically dead.
Right. These patients were in profound, decompensated class 5E hemorrhagic shock. They transfused an astounding 224 units of blood products to these 20 people, and 57% of that was fresh, whole blood drawn emergently from the walking blood bank.
That's a massive resuscitation effort.
And yet, despite these extreme physiologic deficits, 100% of these patients survived to be transferred to the next level of care.
100% survival in an austere tent environment with SPPs in the 70s.
Now, as clinicians, we always have to acknowledge the statistical limitations of the data we consume.
Of course.
This is a retrospective review with a small sample size of N20. It is not a randomized controlled trial.
Right.
But in trauma surgery, when dealing with injuries that are historically 80 to 90% fatal, a clinical signal of 100% short-term survival in this specific cohort is deafening.
It tells us the physiology works. But what is equally critical to the survival rate is who is actually performing these interventions.
Right. I have to admit, this part made me sit up. 40% of these REBOA catheters were placed by emergency medicine physicians, not the trauma or vascular surgeons.
Yeah, that's a big deal.
Let's be honest, in a typical civilian U.S. hospital, REBOA is often fiercely guarded as a purely surgical procedure. The vascular surgery community would have an absolute aneurysm if we broadly suggested EM docs start dropping aortic balloons.
Oh, totally.
What does this military data mean for our team dynamics?
It proves that in a resource-constrained or mass casualty environment, advanced resuscitative care must be a team-based capability, not a siloed surgical skill.
Because there's only so much the surgeon can do at once.
Look at the logistics of a forward tent. If you have two crashing patients, the surgeon needs to be operating on patient A. If an EM physician is trained, credentialed, and competent to place that REBOA in the bay on patient B, they instantly secure zone 1 occlusion.
They stop the subdiaphragmatic exsanguination, preserve cerebral and coronary perfusion.
And buy the surgeon 30 to 45 critical minutes to finish the life-saving thoracotomy on patient A. It is the ultimate force multiplier.
And the source gives an incredibly actionable, brilliant piece of advice for the listener to facilitate this, even if you are the only surgeon in a civilian bay. Adopt the military's early femoral access protocol.
Yes.
When a high-risk mechanism patient rolls in, say, severe pelvic crush, even if their pressure is currently 110 and they aren't actively crashing yet, place an 18-gauge arterial line or a 4 or 5 French micropuncture catheter in the common femoral artery early during the primary survey.
The micropuncture technique using the Seldinger method is brilliant in its simplicity and foresight. First, it gives you continuous, highly accurate, beat-to-beat arterial blood pressure monitoring.
Which is key, because if a patient is peripherally clamped down due to shock, a non-invasive arm cuff is notoriously inaccurate.
The ART line gives you the truth. It allows for immediate arterial blood gas draws to constantly assess base deficit, lactate clearance, and ventilatory status.
Right.
But most importantly, if that patient suddenly decompensates 15 minutes later and you desperately need a zone 1 RBOA, you already have the wire access.
Exactly. You aren't trying to blindly stick a pulseless, flattened femoral artery in a crashing patient covered in blood.
Which is a nightmare.
You just slip a stiff wire down the existing 4 French catheter, upsize it to a 7 French sheath over the wire in a matter of seconds, and float the balloon. That is a pearl every single civilian trauma bay should implement tomorrow.
But we also have to respect the physiology of the REBOA. It is a temporizing bridge, not a destination.
Right, there's a cost.
When you inflate a balloon in zone 1, the descending thoracic aorta, you are intentionally causing profound ischemia to the gut, the liver, the kidneys, and the lower extremity.
The ischemia reperfusion injury.
Exactly. When you finally get surgical control and deflate that balloon, all the lactic acid, the potassium, and the inflammatory cytokines that have built up in the ischemic lower body instantly wash back into the systemic circulation.
And this washout acidosis can cause sudden cardiac arrest.
The austere teams manage this by meticulous, slow titration of the balloon deflation, communicating constantly with anesthesia to push calcium and bicarbonate ahead of the washout.
So you've temporized the hemodynamics with whole blood in a zone 1 REBOA. The clock on ischemic time is now ticking loudly. That brings us to the actual physical intervention. Let's step up to the table.
Let's do it.
In a civilian setting, for a thoracic bleed, we might instinctively position lateral decubitus. Well, I mean, the battlefield data screams otherwise. How do the military's operative paradigms for the chest differ from our standard approaches?
It begins before you even make the incision. It begins with positioning. The source is absolute on this rule. For any truncal trauma, the patient is always, without exception, positioned supine, never in the lateral decubitus position.
Which is deeply counterintuitive for a trained thoracic surgeon who is used to putting a patient lateral for a standard posterolateral thoracotomy to get beautiful, wide-open access to the pulmonary hilum.
But in trauma, especially penetrating or blast trauma, a posterolateral approach is a dangerous trap. The combat surgeon must maintain options because the preoperative diagnosis is almost always incomplete.
Right, you never know exactly what you're going to find.
A massive hemorrhage that you suspect is coming from the right pleural cavity might actually be a transmediastinal injury involving the great vessels. Or it might be coming from the abdomen, a shattered liver, and tracking up through a ruptured hemidiaphragm into the chest.
Right. If the patient is lateral decubitus, you are physically locked out. You cannot access the contralateral chest, the abdomen, or the groin for vascular control.
Exactly. Supine positioning, combined with prepping the patient for the chin down to the knees, allows rapid, unhindered access to the neck for carotid exposure, both hemothoraces, the entire abdomen, and the femoral vessels.
And if you are supine and you perform a left anterolateral resuscitative thoracotomy, but find you need more exposure to the right side of the heart or the right hilum, the source highlights a fantastic aggressive maneuver.
Yeah, this is great.
You don't struggle in a dark hole with poor visibility. You simply extend the incision 5 to 10 centimeters medially right across the sternum, dividing it with a Lebsch knife or a sternal saw.
You essentially create a clamshell or a hemiclamshell incision, giving you massive, undeniable exposure to the heart, the great vessels, and both pulmonary hilum simultaneously.
Exposure is safety in trauma. Now, let's talk about the pathophysiology of what you actually find when you enter that chest, specifically regarding pulmonary trauma.
Okay.
Let's dig into this because this blew my mind. In civilian trauma, a handgun bullet to the lung, a low-velocity wound, often creates a simple through-and-through parenchymal injury.
It's a clean hole.
Right. We are taught to use a linear stapler, pass it through the tract, fire it, and perform a stapled tractotomy. It lays the tract open, you oversew any bleeding vessels, and you're done in 5 minutes. It saves lung tissue.
Yeah.
But Martin and Eastridge warn that the civilian technique will fail spectacularly on high-velocity military rifle or fragment wounds. Why?
We have to look at the physics of terminal ballistics. A high-velocity round, like a 5.56 or 7.62, doesn't just punch a hole. It creates a massive temporary cavitation wave.
The energy transfer.
Right. It transfers immense kinetic energy into the surrounding viscoelastic tissue of the lung. The lung tissue isn't just pierced. It is macerated, shredded, and contused for several centimeters outward from the actual permanent wound cavity.
It turns the lung parenchyma into a bruised necrotic paste.
Exactly. If you try to perform a simple staple tractotomy on macerated tissue, the staples will find absolutely no purchase.
It'll just pull right out.
They will tear right through the necrotic lung the moment the lung inflates, leading to massive rebleeding and, worse, intractable bronchopleural fistulas, because the small airways are blown wide open.
So what is the necessary surgical adaptation?
You must respect the zone of injury. You have to perform a non-anatomic stapled wedge resection that completely excises the macerated tissue. You have to staple across healthy, pink, bleeding lung parenchyma.
Which means sacrificing more lung.
You have to. In severe cases involving the central hilum, this might require a formal lobectomy or even a damage control pneumonectomy using a massive Hiller clamp to stop the bleeding, even though the mortality for trauma pneumonectomy is exceptionally high.
Right, while you are manipulating this shredded, bleeding lung, the source brings up a terrifying, often under-recognized complication: systemic air embolus.
This is a silent killer.
Think about the pressure dynamics in the chest. You have high-pressure air from the lacerated bronchial tree mixing intimately with open, low-pressure pulmonary veins.
It is a lethal anaconical short circuit. If the positive pressure from the ventilator pushes air into the open pulmonary veins, that air travels straight to the left atrium, into the left ventricle, and is pumped systemically.
And the most disastrous destinations are the coronary or cerebral arteries.
It causes immediate, profound ischemic arrest.
Yeah.
The heart just stops, and you literally see air bubbles in the coronary vessels.
The military mitigation strategy for this is wild, but physically brilliant. If you suspect an air embolus risk while operating on that macerated lung, you try to rapidly clamp the pulmonary hilum to isolate the vascular return.
Right.
But if it's a mess and you can't get the clamp on fast enough, you literally flood the operative field, the entire pleural cavity, with warm, sterile saline. You intentionally submerge the bleeding, leaking lung entirely underwater.
It's basic physics applied to surgical salvage. By submerging the injury, the open pulmonary veins will suck in sterile saline instead of room air during the respiratory cycle.
Which is safe?
Yeah, a small volume of sterile saline entering the left heart is harmlessly pumped into the systemic circulation. A small volume of air is fatal. It's a remarkably effective, rapid damage control maneuver.
So simple, but so clever. Let's shift our focus from the lung tissue itself to the pleural space. What about the massive hemothorax?
Okay.
In the civilian ED, if the ultrasound shows a massive hemothorax, the absolute knee-jerk reaction is to immediately place a 36 French chest tube in the trauma bay to drain it. But the military surgeons advocate a radically different approach for these massive clotted collections.
They advocate for the OR washout technique, and it is based on the physical properties of clotted blood.
Yep.
If a patient has a massive, rapidly formed hematoma from a high-velocity injury, placing a standard chest tube in the ED is often futile.
Because it just clogs.
The tube will instantly clot off, you won't drain the chest, the lung won't physically be able to re-expand to tamponade the bleeding, and crucially, the patient remains at massive risk for developing an empyema or a restrictive fibrothorax weeks later.
The retained hemothorax, it's the bane of trauma recovery.
Precisely. The military protocol is to bypass the ED tube entirely. You take the patient directly to the operating room, you prep the chest, make a 2-centimeter incision as if you were placing a tube, but instead you insert a large pool suction tip directly into the pleural space to evacuate the liquid blood.
Just suck it right out.
Then, You use liters of warm saline lavage, aggressively flushing it into the chest cavity to actively break up and flush out the formed gelatinous clots. Only after the chest is physically washed out and clear do you place the large-bore chest tube through that same incision.
It prevents the retained hemothorax and saves the patient from needing a delayed decortication surgery weeks later, where we have to peel the scar tissue off the lung.
It's definitive care masquerading as damage control.
So we've controlled the chest. Let's move below the diaphragm to the abdomen and what the source appropriately calls the nightmare pelvis.
Let's start with solid organ injuries. The liver, the spleen, the kidneys. There is a massive, highly debated divergence here between civilian and military doctrine.
Right. In a U.S. Level 1 civilian center, if a patient comes in with a grade 3 or even grade 4 liver laceration from a steering wheel impact, and their blood pressure responds to a liter of fluid or a unit of blood, we will almost always admit them to the ICU, trend their hematocrit every 6 hours, and observe them.
Absolutely. Non-operative management is the absolute gold standard for blunt solid organ injury.
But the military surgeons operate on almost all solid organ injuries. Why the aggressively surgical posture?
It comes down to two factors: the mechanism of cellular death and the unforgiving reality of the austere environment.
Okay, what about the mechanism?
A blast injury or a high-velocity fragment doesn't just cleanly lacerate the liver. As we discussed with the lung, it causes deep tissue shredding, cavitation, and delayed necrosis.
Oh, right.
That necrotic tissue is highly prone to delayed rupture, massive secondary hemorrhage, or severe biliary leaks days later.
The tissue is essentially a ticking time bomb of ischemia.
Yes. But more importantly, it's the austere environment itself. Non-operative management is only statistically safe if you have the capability to perform serial, high-resolution CT scans with contrast and continuously monitor the patient with one-to-one nursing in a dedicated ICU for days.
Which you absolutely do not have in a forward surgical tent with 10 other mass casualties rolling in.
Precisely. And consider the evacuation chain. If you attempt non-operative management and that patient's spleen decides to rebleed 12 hours later while they are strapped into the back of a C-17 aeromedical evacuation aircraft, flying at 30,000 feet over the Atlantic Ocean with minimal surgical capability on board,
They will exsanguinate and die.
the source dictates a strict rule. If non-operative management is attempted for any reason, a mandatory 48 hours of strict clinical observation and a repeat contrast CT scan must be performed to definitively rule out the formation of pseudoaneurysms before aeromedical evacuation is even considered.
And since forward surgical teams rarely have the luxury of holding a patient for 48 hours, the safest, most definitive route is an exploratory laparotomy to physically assess, pack, or resect the solid organs.
Exactly.
And when we look at hollow viscous injuries, the bowel, we see a similar vital divergence based on physics.
Yes.
In civilian trauma, if there's a small bowel hole from a low-velocity 9mm handgun, we routinely do a primary suture repair. We just sew the hole closed in 2 layers and it heals beautifully.
Yeah.
The military source states that for combat wounds, primary repair has an unacceptably high failure and leak rate. They mandate stapled resection. And the detail that really highlights the why here is the discussion on 50 caliber machine gun effects and the thermal injury zone around IED fragments.
This is the microscopic cellular trap for the civilian surgeon. When a superheated, jagged IED fragment pierces the bowel wall, it doesn't just make a mechanical puncture. The intense heat radiating from that metal fragment instantly cooks, coagulates, and devascularizes the bowel wall for a significant radius, often centimeters, around the actual visible puncture hole.
The zone of coagulation.
Exactly. If you look at that hole and just throw a silk suture across the visible defect, you are sewing dead, thermally injured vascular tissue to dead, thermally injured tissue.
It might look watertight on the table,
But it will invariably break down, necrose, and leak on post-op day 4 or 5, causing a catastrophic, often fatal systemic peritonitis.
so the surgeon must physically resect the entire segment of bowel containing the thermal burn, staple across the healthy, pink, bleeding ends, and often, because the patient is in shock and the gut is poorly perfused, leave them in discontinuity.
The military surgeons use loop-ostomies very liberally to divert the fecal stream because complex devascularized wounds in a patient in shock simply will not heal a primary anastomosis.
It is a lesson in respecting the microscopic damage, which brings us to the most dreaded and mechanically complex combat injury described in this text.
Here we go.
The massive perineal and pelvic blast wound with traumatic amputations.
This is where surgical discipline is tested to its absolute limits.
It is the nightmare scenario. Think about your own bay for a second. I want to set the scene for the listener based on the text. You have a dismounted patient who stepped directly on a pressure plate IED.
Okay.
They have massive tissue loss of the perineum. The anorectal complex is completely destroyed. They have traumatic amputations of one or both legs at the proximal thigh. The bony pelvic ring is shattered into multiple unstable fragments, and they are exsanguinating from profound anatomically distorted vascular injuries in the groin. Where does a surgeon even begin when the anatomy no longer exists?
The primary surgical pearl here is actually a stark warning of what not to do. The authors are absolutely adamant: do not dive into the bloody, distorted groin to seek direct vascular control. It is a fatal, time-consuming trap.
It's so visually tempting, right? You see the arterial spurting, you see the massive hemorrhage, and the instinct is to grab a vascular clamp and dive in.
But the anatomy is obliterated. The femoral veins and arteries have snapped and retracted deep into the shattered pelvis. The hematoma is massive, the tissue planes are gone, and every single second you spend blindly digging in the groin with a clamp, the patient is rapidly exsanguinating.
So what's the alternative?
The mandated military approach is to completely bypass the zone of injury initially. You immediately perform a rapid midline laparotomy or an extraperitoneal approach through the lower abdomen to achieve proximal aortoiliac control.
You go above the blast.
Exactly. You get a vascular clamp on the distal abdominal aorta or the common iliac arteries from above the zone of injury, working in clean, uninjured tissue planes.
Once you have that proximal control from the clean abdomen, the torrential, life-threatening bleeding in the groin immediately stops.
Yes.
Then, and only then, in a controlled, bloodless field, do you explore the groin wounds to identify and ligate or shunt the retracted vessels.
And the source adds another critical, forward-thinking nuance regarding the amputations themselves. Even if the limb is totally destroyed and requires a high, definitive amputation, you must attempt to restore blood flow to the remaining proximal stump, using temporary intravascular shunts, like Argyle shunts, if you cannot primarily repair the vessel.
You don't just tie off the femoral artery as high as possible to stop the bleeding. Why?
Because by temporarily shunting the vessel during the damage control phase, you preserve the arterial perfusion to the remaining proximal thigh musculature, the collateral circulation, and the critical skin flaps.
Which pays off later.
Massively. This aggressive salvage of tissue length is the difference between a patient being able to use a modern, advanced prosthetic socket limb versus being bound to a wheelchair for the rest of their life due to a high hip disarticulation.
And we should note, tying this all back to our resuscitation discussion, these massive pelvic blast patients often bypass the ED completely. They go straight from the medevac helicopter directly to the OR table.
The whole blood resuscitation, the potential REBOA placement by the EM doc, the ketamine induction, and the proximal aortic clamping by the surgeon. It all happens simultaneously.
It is the absolute pinnacle of choreographed, team-based surgical critical care.
Which naturally leads us to the post-operative phase, focusing on austere anesthesia and how these concepts apply to future civilian practice.
We rarely talk about the anesthesia side in these surgical deep dives, but it's crucial. How do these austere surgical teams manage complex multi-hour laparotomies without the massive anesthesia machines, the complex vaporizers, and the inhaled volatile anesthetics like sevoflurane that we take for granted in a civilian hospital?
They rely entirely on total intravenous anesthesia, or TIVA, primarily using continuous titrated infusions of propofol and ketamine. But the real ingenuity, the operational brilliance, is their heavy reliance on regional anesthesia to conserve vital logistical resources. Think about the austere environment. You cannot afford to have a patient languishing on a mechanical ventilator in a tent for 3 days simply because they're in too much pain to breathe deeply after a massive laparotomy.
You don't have the oxygen generators, the spare ventilators, or the respiratory therapists to monitor them.
So they use aggressive preemptive regional blocks. The text specifically highlights intercostal nerve blocks for the massive chest wall trauma we discussed earlier and transversus abdominis plane, or TAP blocks, for the abdominal incisions.
The ultimate physiological goal is early, aggressive extubation. By profoundly numbing the somatic pain of the chest wall or the abdominal fascia, the patient can breathe spontaneously without splinting.
They can be extubated sometimes just hours after a major damage control surgery.
And this is a highly applicable strategy for civilian ICU step-downs. As civilian surgeons, we should be using TAP blocks and epidurals far more aggressively.
Oh, without a doubt. It liberates civilian trauma patients from the ventilator sooner, dramatically reduces the incidence of ventilator-associated pneumonias, decreases ICU length of stay, and frees up critical ICU beds.
It's about optimizing human physiology to reduce the required technological footprint. And looking to the future, the source gives us some incredible data on how to push this physiological optimization even further forward, closer to the actual point of injury. I was absolutely fascinated by the British MERT data, the Medical Emergency Response Team.
This is a paradigm-shifting concept for pre-hospital care. The MERT model involves taking advanced providers, intensive care nurses, emergency medicine physicians, or even fully trained trauma surgeons, and putting them directly onto the pre-hospital medevac helicopters, bringing advanced resuscitative interventions and whole blood directly to the point of injury in the field.
And the data they published from the Afghanistan experience is statistically striking. For moderately injured patients, the mortality rate dropped from 18% with traditional medic-led pre-hospital teams down to 12% with the MERT advanced provider model.
And the p-value on that was 0.035, making it statistically significant.
That is a massive absolute risk reduction in mortality just by shifting the clinical expertise in the blood products closer to the point of wounding.
It directly challenges the historical civilian EMS philosophy of scoop and run. If you can initiate warm, whole blood resuscitation and advanced airway control during the transport phase, you arrive at the hospital doors with a patient who is physiologically intact, rather than one who is irreversibly spiraled into the lethal triad.
Which brings us to the final and perhaps most mind-bending sci-fi concept in this entire chapter. We spent this whole deep dive talking about the supply side of hemorrhagic shock.
Right, replacing the lost blood volume, clamping the aorta to supply blood to the brain, supplying oxygen to the tissue.
But Martin and Eastridge propose a completely different revolutionary future direction, addressing the demand side of shock.
This is the holy grail of trauma research. We are talking about inducing cellular tolerance to profound ischemia. Let's look at the biochemistry. Currently, when tissue loses perfusion, say the bowel, during a Zone 1 REBOA, it rapidly burns through its ATP stores.
It shifts to inefficient anaerobic metabolism, produces massive amounts of lactic acid, the sodium-potassium pumps fail, the cell membranes rupture.
And it leads to irreversible apoptosis and necrosis. But what if we could pharmacologically tell the mitochondria to simply stop demanding oxygen?
The source mentions specific compounds currently showing immense reproducible promise in animal models of severe hemorrhagic shock. Drugs like valproic acid, hydrogen sulfide, and high-dose estradiol.
These agents act directly on a mitochondrial level to downregulate cellular metabolism. They essentially induce a temporary state of suspended animation, a localized artificial hibernation.
The clinical implications are staggering. If a frontline combat medic or a civilian paramedic responding to a highway pileup could inject a demand-side hibernation drug into a bleeding, trapped patient at the scene, the cells would simply stop dying from lack of oxygen.
The metabolic clock on ischemic necrosis would be paused. You could theoretically have a patient with a Zone 1 REBOA, occluding their aorta for over an hour, or a patient mechanically trapped in a crushed vehicle for 3 hours, and their liver, kidneys, and gut would completely survive the profound ischemia because their metabolic demand was pharmacologically turned off.
It changes the entire timeline of the golden hour. It rewrites the rules of ischemic time. So think about your own practice. For you listening right now, when you walk into your bay tomorrow, imagine the impact. How would a pre-hospital hibernation drug change the way you receive and triage patients?
If the tissues are pharmacologically protected from ischemic death, does rapid damage control surgery suddenly become meticulous definitive surgery? Do we stop rushing to staple and resect bowel and take the time to beautifully reconstruct the anatomy because the metabolic clock has stopped ticking?
It's a future that isn't just science fiction. Based on this military research, it is actively being engineered in labs right now.
The battlefield has always been the tragic, yet undeniable laboratory for surgical advancement. The clinical paradigms detailed here, from the absolute superiority of whole blood to the physiologic trap of early intubation to the extraperitoneal approach for massive pelvic hemorrhage, were paid for with an incredibly high human price.
It is our absolute duty as surgeons to rigorously understand the pathophysiology behind them, to adapt them to our civilian environments, and to apply them when the next critical patient rolls through our doors.
Well said.
Thank you for joining us on this deep dive into the operative realities of the modern battlefield. Take these lessons, internalize the cellular physiology, and use them to give yourself the edge on your next critical shift. We'll see you next time.